I'm here with Dr. Amit Chopra, and we are talking about the link between mental health, depression, and sleep issues. This channel is for you, the healthcare practitioner. So if you are a physician, if you're a nurse practitioner, PA, or another type of healthcare professional interested in learning more about sleep, this channel is for you. Dr. Chopra, thank you so much for joining me today. Can you tell our audience a little bit about your background and what you do?
Hi, Dr. Bhopal. Thank you for the opportunity today. So my name is Amit Chopra. I'm a psychiatrist and a sleep specialist working at Massachusetts General Hospital. I'm an assistant professor of psychiatry at Harvard Medical School. I also run a private practice in the states of California and Massachusetts, providing services for sleep and psychiatric conditions. And I'm an author of a book called Management of Sleep Disorders in Psychiatry.
Wonderful. So I'll put those resources in the video description underneath. You can go check out Dr. Chopra's website, his private practice, and his book. And I'm glad to have you here today because there is such an important link between mental health. Specifically, we'll talk more about depression today and sleep disorders. Yet there's not a lot of us out there who are psychiatrists and sleep doctors. So I'm always excited when I meet another psychiatrist who's also board certified in sleep. So maybe we can jump right in. Can you tell us a little bit about the link between insomnia and other sleep issues and major depressive disorder? Why is this important for clinicians to know?
Great question. As we know, major depressive disorder is characterized by almost universal presence of sleep disorders, predominantly insomnia, and this can start as a prodrome or during depressive illness that people start to have difficulties with sleep initiation and so early morning awakenings. And more likely than not, it is considered as a secondary symptom of depression, meaning the depression started and the insomnia was a consequence of it. And this particular view is definitely not helpful just because it takes the clinical attention away for treatment of insomnia, which is a prerequisite for an optimal outcome with treatment of depression. So thankfully, the perspective has been changing and there's a robust evidence that supports a bidirectional relationship between the two, meaning the sleep disturbances and major depressive disorder are bidirectional in nature. Each one of them can predispose to the other condition. And this thanks to a lot of longitudinal studies that have happened and a meta-analysis that supports the hypothesis that people who have persistent insomnia symptoms, meaning insomnia going on for more than 3 months, are at a higher risk of developing depression down the line as compared to those without insomnia symptoms. So if you look at the meta-analysis results, the risk of having major depressive disorder in those with persistent insomnia is twice as more likely as compared to somebody without insomnia symptoms. And this absolute risk increases much significantly in adolescents, where the risk is almost 4 times higher than adolescents do not have insomnia, and how likely are they to develop depression in the future. So on a good note, the clinical side has also paid attention to this, and DSM-5 has abolished the categories of primary versus secondary insomnia, and now we call insomnia as an insomnia disorder. And I think these are very promising changes, and I think this is an opportunity for us to look at insomnia as a risk factor for depression, because now we can intervene in people who have insomnia and maybe prevent onset of depression, and that's where the research field is moving.
I think that's a really important point, that the relationship is bidirectional. When you have depression, it can make insomnia worse. And then, as you said, having insomnia can increase the risk of depression and increase the risk of relapse of depressive symptoms, even if the depression is treated. What about other sleep disorders? Because I know when I speak with clinicians about sleep, usually they're thinking about insomnia only, but there are other sleep disorders that can be comorbid with depression. So can you tell us a little bit about what those might be and how common might they be compared to insomnia, which affects about 85% of people experiencing depression?
Yeah, I think it's very important to conceptualize sleep dysfunction beyond insomnia and MDD, because MDD is very prevalent with other sleep disorders, including obstructive sleep apnea, restless leg syndrome, circadian rhythm sleep disorders, and even disorders of hypersomnolence, such as idiopathic hypersomnia or narcolepsy. So I think there's more research coming to our notice that is establishing a bidirectional relationship with most sleep disorders, including insomnia and MDD. For example, the prevalence of sleep apnea in patients with MDD is around 20%, maybe higher in people who are more treatment resistant. And there's more evidence coming that, or showing us that diagnosis of obstructive sleep apnea can make people predisposed to having a future onset of major depressive disorder. Similarly, with restless leg syndrome, people with MDD are at least 2 to 3 times higher risk of having restless legs as compared to general population. And similarly, the risk is equal in terms of restless leg patients, people who have restless leg syndrome, to develop MDD in their lifetime. So I think these are very important metrics to be aware of, and to think of sleep dysfunction broadly and not just focusing on insomnia and MDD.
I'm curious what you see when these sleep disorders are ignored from a psychiatric perspective.
I think the consequences are significant. Let's take an example for insomnia. If we do not treat insomnia effectively, I think we leave the remission of depression behind, just because there's at least 3 to 6 more times risk of having a recurrent depression episode if we leave the insomnia untreated. And that has huge consequences on the outcomes in a person with MDD condition. And similarly, a lot of functional impairment that goes along with people who have sleep dysfunction, including insomnia or other sleep problems like sleep apnea or restless legs, comorbidity with MDD, and that impairs their overall functioning and overall, say, outcomes with treatment. And I think if we leave those conditions behind and do not recognize them or do not treat them adequately, then the outcomes are going to be suboptimal. And we see the picture of partial response, non-response, or even treatment resistance, where patients are having a very tough time getting a response with standard antidepressant treatments.
Why is it so important that we are assessing for patients' sleep issues and treating them? So in other words, what is happening to the brain or what's happening with their sleep quality that's impacting their mood negatively?
I think sleep disorders and major depressive disorder, particularly there's more research on insomnia and MDD, they share quite a few common neurobiological mechanisms, including neurotransmitter dysfunction, activation of hypothalamic pituitary axis, and impaired neuroplasticity. And due to these mechanisms, so patients have a dual impact on their symptomatology, and it's a shared impact because of two comorbid issues like insomnia and MDD, where they have more fatigue, where they have more cognitive impairments, where they're having excessive ruminations that are reinforced by lack of sleep, and that affects their thinking and their tendency to have suicidal ideations. So I think we need to keep all those considerations in mind when we see people with comorbid sleep issues and MDD and look at their clinical presentation.
Yeah, and I think that's a great explanation. And it's also something to share with our patients, explaining to them why we're doing this sleep assessment. Because sometimes when I'm working with patients on the psychiatric side, sometimes there's a little bit of resistance to engaging in some of the assessments for sleep issues, like doing a sleep study or pursuing treatment, especially if they have sleep apnea. Sometimes there is resistance to that, or even engaging in CBTI. So how would you explain it? Like, how can a clinician explain to their patients, I know we're working on your depression, but sleep is such a foundational part of that, and that's why I'm recommending these assessments or interventions. What should clinicians be saying to their patients?
I think the first step here is to explain how deeply intertwined the sleep and mental health issues are. We can take an example of depression and insomnia. And I think then explaining how the insomnia makes their symptoms worse and their quality of life worse, and how the assessment would lead to an accurate diagnosis, and how that can change their outcomes in terms of better response to antidepressant treatment, better quality of life, remission time where they are not having a recurrent episode. Whereas if we don't treat the problem, then they're at a much higher risk of having a recurrent episode and maybe eventually turning into a treatment-resistant depression, which may have a very difficult course for them to go through.
So, for the clinician who is maybe a psychiatrist or their primary care doctor working with that patient who has depression, do you recommend focusing more on clinical history? At what point should they order a sleep study because OSA is so prevalent as well with MDD? So, how can the non-sleep clinician approach this? As you can see, there's a lot to learn when it comes to clinical sleep medicine, and we're just scratching the surface in today's interview. If you are a physician or a health practitioner who wants to learn more about clinical sleep medicine in a practical way that you can use in your everyday clinical work, then get my free sleep mini course. I'll put the link to that in the video description below. You can also get it at intrabalance.com/doctors.
Yeah, I think I try to take sleep on a 24-hour continuum when I'm assessing people in my clinic. So I think the first step is to get a very good history in terms of what the sleep latency is, how long the patients are taking to go off to sleep, what is the wake after sleep onset time, meaning how long they're awake in the middle of the night once they've fallen asleep, and then what's their sleep efficiency, meaning how much are they sleeping when they're in bed. And I think these are three important parameters in addition to the total sleep time that I would definitely recommend clinicians to obtain. This will give us an idea of where the problem is. If somebody's taking more time to go off to sleep, so definitely that points towards sleep maintenance, sleep initiation insomnia. And then we can dive into what's going on at that time. Is there anxiety? Is there rumination? Is there a pain condition? Is there an environmental issue? Is there a lack of sleep hygiene? Actually, what is causing the issue there? And more often than not, there are multiple factors that drive the insomnia, either sleep initiation or sleep maintenance. And I think that gives clinicians more opportunities if we assess that in detail to intervene rather than advising one or two generic suggestions for improvement in their sleep. And also, in addition to these nighttime sleep parameters, I look at how many naps are patients taking during the daytime, how much time they're spending in bed, what are they trying to do to compensate their sleep deficits, either insomnia or hypersomnia. If they're feeling sleepy, are they taking excess caffeine, soda, or if they're not able to sleep, are they using alcohol or cannabis to help them to go off to sleep? And then their occupational patterns, they're working in a way that makes them prone to have shift work problems or any other travel issues that may cause circadian rhythm problems, such as jet lag. So I think it has to be very thorough and very comprehensive. And then also having to assess for other sleep disorders is very important, such as sleep apnea. The simple questioning may be, are you snoring? Are you having any pauses in your breathing? And are you waking up gasping or choking? Are you waking up with headaches or dry mouth first thing in the morning? And how sleepy you are during the day. I think I very commonly see people with sleep maintenance insomnia, they end up having obstructive sleep apnea, which is relatively underdiagnosed and undertreated, especially in psychiatric populations. Similarly, for sleep initiation problems, certainly have to look at their circadian rhythms, see if they have night owl tendencies, or if they have restless leg syndrome, which is interfering with the sleep initiation. So I think the whole sleep assessment may not take more than 10 to 15 minutes, but once it is done, I think it can give us some very valuable insights into what's going on with sleep and then come up with a comprehensive plan how to investigate it.
That was excellent. I'm glad that you mentioned the differential diagnosis of the sleep onset issues. That could be circadian issues. It could be restless leg syndrome. And the sleep maintenance issues could be a sign of obstructive sleep apnea. And what I tell people is that insomnia is not always insomnia. So we have to be very careful as clinicians not to label something as an insomnia disorder before we do this additional clinical history assessment and workup. And last year, I had 4 women who were referred to me for treatment-resistant insomnia. So they were referred by their psychiatrist because I run an insomnia clinic. And so they were referred to me for treatment-resistant insomnia. They all had sleep maintenance issues, not responding to the usual CBTI and pharmacology interventions. So I did sleep studies on all of them. They all had moderate to severe obstructive sleep apnea, and they all had comorbid depression. And with treatment of their sleep apnea, the depression improved. And so I'd like to share that story because it illustrates the types of things that we're seeing in clinical practice.
It's very pertinent. I'm so glad that you brought this up. And I think with females, there's a propensity for REM predominant OSA, which manifests more during the REM sleep, which is the latter half of the night. So we see that quite commonly, especially in sleep clinics, when people are presenting with sleep maintenance issues, depression, and their insomnia is not getting better, just the way your patients presented. And if you take more comprehensive history and look at some other factors, you might be able to clinch the diagnosis.
Yes, absolutely. And so for the clinician, if you're listening and you're thinking, I don't have time to go into all of these questions in a visit, maybe I only have 10 minutes and they're coming in for hypertension and I don't have time to go into all of this stuff. What I recommend is you can actually just get a sleep history template and you can have that sent to your patient and they can fill that out to get a lot of that data. You can also use screening tools like the Stop Bang questionnaire, even though there's limitations with that, but different rating scales that are validated, you can use those in your practice as well and send them to patients ahead of time. And that's something we teach I have a clinical sleep program for clinicians to learn about how to do the assessments and workup. And so that's something that I do encourage people to do. And Dr. Chopra, do you recommend using any particular type of sleep diary, or if the patient has a wearable like an Apple Watch or an Oura Ring, do you use that data in part of your assessment?
Yeah, I welcome input from patients who are using these technologies because not everybody may not be able to afford these, but I think that's a valuable data point that needs to be looked at. I generally try to tell people to keep an account of the most important variables that determine the sleep continuity, how long they're taking to go off to sleep on an average. It should be 30 minutes or less. That's the sleep onset latency. And what's the wake after sleep onset time? Again, that should be less than 30 minutes, meaning how long they're up for in the middle of the night, and the total sleep time and the sleep efficiency, which is time slept or bedtime in bed. And we need to hit the 85% or above to have a good sleep efficiency. I think I try to make it more conducive to people. If somebody is interested in maintaining a sleep diary, that's excellent. But I would certainly want variables discussed in my follow-up visits with patients and see if we're making progress or not in those variables.
What point should a clinician order a sleep study?
Yeah, I think for insomnia, as we know, we don't have to order a sleep study if it is the first presentation. But as you pointed out clearly in your cases, when people are having treatment-resistant insomnia and traditional treatments are not helping, I think that's a reason to consider sleep study. I think more importantly, if somebody has history or risk factors for sleep apnea and their insomnia sleep maintenance in nature, I think that would point towards ordering a home sleep study or in-lab sleep study based on other medical conditions that the patient may have. If there's a concern for periodic limb movement disorder where there's excess movements during sleep or parasomnia behaviors, definitely we should order an in-lab sleep study. And when in doubt, you can check with a colleague in sleep medicine or consider these factors. And if somebody is at a higher risk of any sleep disorders that need investigation in the lab, go ahead and order the sleep study.
Another aspect of sleep and mental health that we know is that insomnia is an independent risk factor for suicidality, independent of depression. Could you speak about that and how you think about that clinically?
It's a very important point that you raised. Indeed, insomnia is a risk factor for suicidality, independent of depression, and there are different mechanisms it works through in terms of increasing the suicidality by increasing hopelessness, by increasing emotional dysregulation, by increasing ruminations. And as we know, evening time, nighttime is the time when people are more prone to act on these thoughts because they're feeling detached from the world, they're away from their social support network. So it's highly important that we look at insomnia as a modifiable risk factor. So I think that's the plus point here, that we can modify the insomnia symptoms. And there's more research coming that shows CBT for insomnia can be effective in reducing suicidal ideations in both civilian populations and veterans. In my clinical assessment, I look for some clinical symptoms that accompany insomnia, which can put people at high risk of suicide. And these include most daily sleep disturbance, sleeping less than 4 hours per night, early morning awakenings that are a sign of melancholic depression, and nightmares, whether or not comorbid with PTSD. If all those clinical features are present in somebody who's in your clinic and expressing SI, I would take their suicidal risk at a higher risk as compared to other people who may not have these features. And I think sleep interventions need to be provided as emergently as possible, and more serial monitoring of their suicide risk needs to be done to maintain their safety.
Yes, and you mentioned CBTI, which is cognitive behavioral therapy for insomnia. Could you explain briefly what that is?
Yeah, that's the most evidence-based treatment for management of insomnia, both for insomnia on its own or if it is comorbid with psychiatric disorders. And it is a combination of 4 techniques: stimulus control, which reaffirms the association of sleep with the bed and the bedroom environment. And when people are not able to sleep, they are asked to leave the bed and not stay in bed for longer than 15 to 20 minutes. And I think that kind of helps the positive association of bed with sleep. And the other intervention is sleep restriction, where the time in bed is limited. And this intervention improves the sleep efficiency. And this has to be done under the supervision of a sleep psychologist or a person who's trained in CBTI. May not be the best choice if somebody has a history of seizures or bipolar disorder or very severe anxiety that could get worse. But I must say that stimulus control and sleep restriction techniques are the most effective techniques that bring relief for insomnia in patients who are considering CBT for insomnia. And then there's a set of cognitive restructuring techniques to address sleep-related cognitions that may not be helpful and that may perpetuate or maintain insomnia. And then finally, there's a range of relaxation activities that people can do to decrease the cognitive or physiological arousal. On a good note, it is effective in 60 to 70% of the people who undergo this treatment, and it can be delivered on an individual basis, on a group basis, and now digital CBTI has been approved by the FDA for treatment of insomnia. I must say that depression can be a barrier sometimes in pursuing CBTI. So we have to combine CBT for depression and CBT for insomnia together in these patients, especially if there's a tendency to stay in bed, because that will hamper the ability of the person to pursue sleep restriction or stimulus control techniques. And then higher the level of ruminations or depression, sometimes it's hard to comply with CBT for insomnia treatment. So we need to combine these interventions for us to see the optimal effect. And when they're combined, we do see a greater compliance with the treatment and better outcomes with mood and sleep.
How do you see CBTI fitting into other treatments for depression, like psychopharmacology, TMS? You mentioned cognitive behavioral therapy. How do you see it fitting into the treatment plan?
Yeah, I would call CBTI as a treatment amplifier. simply put, just because there's a lot of data that suggests if you add CBTI to antidepressants, it increases the response and even remission. And there are some studies that compare CBTI and placebo with CBTI and antidepressant. And CBTI on its own has been shown to have mild to moderate antidepressant effects. So that's a very positive news for people who are struggling with both sleep and depression issues. And one treatment can help both insomnia and mood to some extent. There's a lot of literature to support adding CBTI to antidepressants. With neuromodulation techniques, I think the literature is emerging in terms of their own effects on sleep, such as TMS. It has shown some efficacy in improving insomnia. In fact, I led a study in Pittsburgh where we did deep TMS for treatment-resistant depression, and we analyzed scores for mood, anxiety, and insomnia on a prospective basis. And it was not a randomized control trial, but what we did notice was that when people's mood and anxiety was improving, so did their insomnia. So I think we need to have more control studies to explore the effects of modulation interventions for people with treatment-resistant depression and insomnia, and maybe then come up with ideas how to integrate TMS with CBTI, because as we know, TMS for OCD works better if you add CBT and ERP for OCD. So there's probably some room there, and we have to identify those patients correctly who would benefit from such treatment. So I think the future looks quite promising in terms of adding CBTI to other interventions for treatment of depression.
CBTI is, like you said, it's an amplifier for depression treatment. It can also prevent the onset of depression. There is research suggesting that. And it can help reduce anxiety symptoms. It can help reduce sleep disruptions from vasomotor symptoms for women experiencing menopause. There are so many benefits to it beyond sleep itself.
Absolutely. I think it decreases the hyperarousal. That is the core factor driving the insomnia. And then I think that can lead to subjective improvements with mood and anxiety and other symptoms that people may experience.
Now, what about the role of pharmacology? So using the hypnotics, some of the new dual orexin receptor antagonists, how do you conceptualize using those in insomnia treatment for patients with depression?
I think that's a very good question, because as the biggest limitation of CBTI is access. We do not have many trained people to do this actual CBTI. And I think to fill that gap, we now have digital CBTI interventions. But I think that may not be accessible to everybody, and we have to resort to medications at times. But I always discuss this with my patients that this is not the first line treatment. This is obviously a second line treatment, so that they're aware that CBTI exists as a first line modality. And if they have means or resources to access it, I would prompt them to do that first. But if the severity of insomnia is quite prominent and negatively affecting someone's sleep and functioning, I think in those situations, we have to resort to some immediate measures. So there's some data that benzodiazepine receptor agonists, esopiclone or zolpidem, have shown some efficacy and safety in treatment of insomnia in patients with MDD. There are only a few trials suggesting that. I think there's some literature emerging on the role of dual orexin receptor antagonists, such as lemborexant or Orexin, in terms of efficacy in insomnia. So that is a promising sign. And there's some more research coming along with selective orexin 2 receptor antagonists, such as seltorexant, that was recently compared with Seroquel in terms of its, or quetiapine, I must say, in terms of its effects on both mood and sleep in people who had not responded to mood and sleep issues with standard antidepressant treatments. And I think the effects were comparable in terms of sleep and mood. So that's another very positive development. I think we need to have more studies to confirm the role of these medications. So I think in terms of selecting a medication in that situation depends on a person's preference, their type of insomnia symptoms and any risk factors that would predispose them to have a negative outcome. For example, if somebody is coming to me with sleep maintenance problems and there's no concern for sleep apnea, I would think about doxepin as first line because it is FDA approved for sleep maintenance issues. Similarly, if somebody has a history of substance use issues, then I would favor using dual orexin receptor antagonists for management of insomnia. And if somebody doesn't have any of these issues and sleep initiation problems or middle of night insomnia, I think sometimes using Zaleplon or Zolpidem can be helpful. And then we know that there's some evidence behind Lunesta. Not only it has shown improvement in insomnia symptoms, but it has shown to hasten the antidepressant response as well, at least in one. So I think they're all good options. We have to choose them wisely based on the type of sleep problem and other medical conditions that a patient may have.
Great. Yeah. So I think just to recap, so step one is doing the assessment and figuring out what the diagnosis is, because insomnia could be a symptom of obstructive sleep apnea, restless leg syndrome, circadian rhythm disorder, and so on. And so, of course, the medications we just discussed are not going to be addressing those issues. So step one is that assessment, get the right diagnosis. Then step two, if it is insomnia, CBTI is first line gold standard, incredibly effective. And it can be done in a variety of different ways, like you said, in person, online, group, individual. I have a few other videos on CBTI, so if anyone wants to learn more about that and learn what resources are available, you can check out those videos too. And then the next step is if they do need some augmentation with medication support, we just went through the various options. And interesting, because when I talk to other sleep physicians as well, they all say the same thing, that, what you just said, CBTI is the most effective. So that's what we want to start with. And I asked the other day some of my sleep colleagues, what medications are your go-tos for insomnia? And they're all like, none. I don't really prescribe medications that much for insomnia. We're focusing more on those behavioral interventions that are much more effective and durable over time. What are some of the biggest barriers to treating insomnia in psychiatric or primary care practice?
I think the biggest barrier is the lack of access to the first-line intervention, that is the CBTI. And I've been a proponent of incorporating CBTI treatment within primary care. And I think the way we can do it is to provide access to digital CBTI as first-line treatment for people presenting with insomnia and mood complaints in primary care. And then having a stepped care model where we can have either group or in-person CBTI if somebody has not responded to CBTI adequately. And then I think then the next level in care can assess for other causes of insomnia more broadly. I think that should be done in the first level of intervention as well. But I think the patient has a fallback. If the first intervention is not helping, then the second step should be more comprehensive, more thorough, and more effective. So I think that's how I would approach it. And I personally feel the need that there's a huge requirement of CBTI trained professionals within psychiatric practices. And if you look at mood disorders, if you look at PTSD, if you look at anxiety disorders, I think sleep disorders are everywhere. And if we ignore or undertreat or not adequately recognize that aspect of care, I think we are doing partial care to our patients who do not then get the best results.
I totally agree with that. There is a need. And the wonderful thing about having all this technology now is that it's becoming more and more accessible.
Yeah, I think there's more and more data coming out. And there was a study that looked at almost subjects, and they recruited primarily for insomnia, but they had subthreshold depression symptoms as well, not meeting criteria for MDD. And after a year's follow-up, those who had the digital CBTI intervention as compared to those who had just online education about sleep, they had much better remission of their subthreshold depression symptoms, and their risk of incident depression was reduced to half. So that is very powerful data that if we can provide this intervention to people early on when they're not in the depth of depression, having some depression symptoms, mainly struggling with sleep, if we can reduce those depression symptoms, reduce the onset of depression, and treat the insomnia effectively, I think nothing supersedes it.
So, on a personal note, what is one thing that you always do in the 30 minutes before you go to bed?
I just put the phone on downtime, that I don't access the phone anymore between 10 o'clock and 7 o'clock during the night and early morning. And I try to engage in some boring, relaxing activities. Sometimes I read a book. Sometimes I might fold laundry just to kind of get myself tired. And then once I'm yawning and feeling heavy-eyed, can't take it anymore, I just shut the light off and try to go to bed.
Dr. Chopra, thank you so much for being here today and sharing your expertise. I know we could go on, and this is such a vast topic, so I really appreciate you being so generous with your time. Where can people find you, and can you tell us again about your book?
So about the book, this is a book that was published in 2020 under the title Management of Sleep Disorders in Psychiatry. I was very lucky to have input from sleep leaders across the globe. And we have 3 sections in this book that highlight the primary sleep disorders, the basics of sleep physiology, and then the most important part of the book is how sleep disorders can manifest in a range of different psychiatric disorders, including major depressive disorder, bipolar disorder, schizophrenia. There are sections on neurological disorders and child psychiatry. So I think it is probably a very comprehensive compilation of resources in terms of what clinicians need to know when they're seeing patients in different capacities and different divisions. And it is not something that's focused on insomnia alone. We have taken a very comprehensive look at it in terms of sleep dysfunction that could be prevalent amongst psychiatric patients.